Well, welcome all to our ASBMR clinical workshop series, which we organized on behalf of the ASBMR Early Stage Investigator Committee. The topic of today's webinar is entitled Osteoporosis Genetics, and again, we have amazing speakers. Professor Duncan is consultant physician and specialist in endocrinology, and she is internationally rewarded for her research in osteoporosis genetics. She originates from Australia, but for her clinical training in endocrinology and the Ph.D. in osteoporosis genetics, she temporarily lived in the UK. She published multiple high-impact papers into the genetics of many endocrine disorders, including particularly osteoporosis and skeletal dysplasias. She recently moved back to the UK, where she takes up a new appointment as Professor of Clinical Endocrinology at King's College London. And Professor Duncan will present the case today with Dr. Oei. She is internist endocrinologist and assistant professor in bone research, especially genetic epidemiology, at the Erasmus Medical Center and also Leiden University Medical Center, the Netherlands. And she is part of the Genetic Factors for Osteoporosis, or GFOS consortium, and she also the Fidelio consortium, which is a training network for research in bone fragility in diabetes. She published multiple high-impact papers, and she is a member of the ECTS Academy. Today's session will be moderated by Dr. Elena Zurdi from Dresden University, Germany, and also by myself. I'm Elizabeth Winter from Leiden University, the Netherlands. At the end of the presentation, there will be enough time for questions and answers, around 20 minutes. And please use the Q&A tool for questions. You can already submit these questions during the presentation. Actually, we prefer that so that the moderators can structure those questions. And I would like to remind not to use the chat function for the questions. So I would like to hand over to Dr. Ling for the first presentation, part of the presentation. Thank you.
Yes. Well, good morning, good afternoon, good evening, everyone. I'm very grateful for this invitation through the ASBMR by my friends to give this webinar together with Professor Anna Duncan. And I'll start off. And I brought a case, which is from Leiden, but as I said, I also work in Erasmus MC and also as a general internist at 2 other centers during COVID. Proud member of ECTS Academy and I said the Fidelio Consortium. So I would like to acknowledge my lab in Erasmus, where I've trained now more than 10 years, and especially the new generation that's even younger than we might be of PhD students supporting us. And I'm very grateful for this very interactive collaborations I have with my colleagues in Leiden and in Amsterdam. So Dr. Lisbeth Winter here moderating, Anna Greet, and to acknowledge here the case that we're bringing by Dr. Appelman, and previously this patient had been treated by Professor Papapoulos in Leiden. So we'll discuss a 47-year-old man who had osteoporosis and fractures already from a young age. He came to clinical attention in adolescence, and looking back, he had multiple fractures. It was remarkable that at the age of 17, already osteoporosis was found, and then a bone biopsy was performed, which showed a narrow cortex and increased bone turnover. Initially, the working diagnosis was osteogenesis imperfecta, or OI type 4. So he was treated with calcium supplementation and at times vitamin D supplementation, and in addition, dihydroxide or etidronate. Then another bone biopsy was performed because they were in doubt about the working diagnosis. However, it showed a similar picture. Later, they performed fibroblast cultures, but they were negative for OI, so they revised the working diagnosis instead to osteoporosis of unknown origin. The bisphosphonate that was administered orally was discontinued. Also, during this follow-up, the deficiency of vitamin D was quite prominent, and the supplementation doses were increased. However, compliance was suboptimal. Then in his 30s, his asthma, which was already known, became a problem, and it was needed to get some short courses of corticosteroids, oral tablets, and also inhalation by corticosteroids. To make things worse, also hyperthyroidism occurred, and as TSH receptor antibodies were clearly positive, we're speaking about Graves' disease. After 1 year on medication, there was remission of disease. Then at age 40, he had a fall. He was quite active person, and vertebral fracture was found, which we'll show on the radiograph after these tables. Then also hyperthyroidism recurred, but it was very short and no action was needed. Finally, at age 43, he had a severe psychosis, and olanzapine medication was started, and he also got EMDR therapy by a psychiatrist. Then finally, age 44, he had some more toe fractures after a fall, and it was discussed with colleagues here if he should be treated again. So he was tried on alendronic acid. Also, we will see the BMD results after this introduction. However, again, no compliance, even though he was slightly older now. After this, he was switched to zoledronic acid yearly. And at that point, also teriparatide as an option was discussed, but we'll go into that in the epilogue of this presentation. And now, as I said, he's 47 years old, and he is still coming back for his zoledronic acid. Looking into family history, it was quite striking that his young kids, age 19 at that point and 17 years old, had multiple fractures. Only his youngest son did not have fractures. Unfortunately, both his parents had died at very young ages, one of them due to alcohol-related causes, and his father due to lung emphysema. So we could not get to their data. Physical exam, no abnormalities were found. Then the DEXA results. So initially, that was around his 20s, the Z-scores were already remarkably low. So at the hips, -2.2, and you can see the course here. As said before, but that's before the graph starts, he was also on an oral bisphosphonate for a few years. And then in the new system we see here in his 30s, he's still around the border of osteoporosis. And we see some decline here. And then zoledronic acid was started as discussed. For the lumbar spine, the Z-score was -2.3, also fluctuating BMD course as seen here. And we also discussed that he had a thoracic 3 vertebral fracture due to trauma. And you could debate if these thoracic other vertebrae show some impression of the end plates and some decrease in vertebral heights. So we had this 47-year-old man, osteoporosis and fractures. So extensive lab screens were done throughout the years. And most striking were the hypovitaminosis D with low compliance of suppletion and the primary hyperthyroidism at times. In addition, gonadal hormones were screened, no parathyroid hormone abnormalities, urinary calcium was checked, and mastocytosis, celiac disease ruled out, and also the other general panels, including inflammatory parameters, were normal. So our intermediary conclusion, a 47-year-old man with osteoporosis, including decreased BMD, and several non-vertebral, but also vertebral fractures, and a marked possible familial predisposition. So next, genetic testing of the patient was performed, and as said, unfortunately, no family members could be accessed as both parents had passed away. He did not have good contact with more distant relatives, and his kids were quite young, and they were not available for testing. So panel sequencing was performed. At that point, it was a few years ago, 19 genes were checked, as you see here, displayed in the gene names here. Illumina HiSeq was used, and sequencing of exons and splice sites was performed with at least 30 times coverage of 99% of these genes. And this is performed in Amsterdam. After this, a Wind1 variant was found where the T was substituted by a C, which was also missense mutation, as there was a substitution of an amino acid. However, if we look at the chemical prediction, there's not a large difference in properties. It was in a reasonably evolutionary conserved region, so it might be of interest. Nevertheless, we speak of a variant of unknown significance and questionable if it's pathogenic. So just briefly about Wind1, you see it in the diagram here with canonical Wind signaling. Wind1 usually binds to the LRP5 frizzled receptor complex, which then enhances Wind signaling in the osteoblasts and osteocytes. Wind1 mutations have been described in early onset osteoporosis and in osteogenesis imperfecta. They're usually a much more severe phenotype and also vertebral fractures, as seen here and described in the New England, among other papers a few years ago. If we look into the variant, we see here that it's described by the SNP number, this RS number, and it's around some better known variants or mutations. Only this one has not been previously described. And interestingly, it's very rare, as we see here from the minor allele frequencies below 1%, even in the large databases. And for example, in UK Biobank, it is not present. If we look it up in the IFMRS musculoskeletal knowledge portal, we see that the prediction is different among the different databases. So polyphen in this version says it's benign. In the other version, it says possibly damaging. For SIFT and the mutation taster, it's predicted to be deleterious and disease-causing. So how to interpret? That's what we're going to discuss next. Now I would like to highlight, as I discussed with Professor Duncan, something about two studies that have been performed in patients who had actually Wind1 and PLS3 mutations. In this first case, it's about teriparatide. In this study by Professor Uti Makti and group, there were 6 adult patients, of which half had the Wind1 mutation and the other half had PLS3 proven mutations. And these people were treated with teriparatide daily for 2 years. At the start and also after the 2 years, transiliac bone biopsies were taken. Also, expression levels of, as seen here, FGF23 and sclerostin were taken. And from this, we can see that teriparatide decreased the osteocyte lacuna size. It increased trabecular bone FGF23 expression and increased sclerostin in the cortical bone. However, teriparatide had little effect on matrix mineralization or bone formation. Finally, a study by Professor Duncan here and colleagues, risedronate was administered to adults with osteogenesis imperfecta type 1. And we see here that in these 32 patients with completed follow-up with a mean age of 39, they were treated for 2 years of risedronate weekly. And the primary outcomes for bone mineral density at the hip and spine, they improved. However, we will see that the bone turnover markers also improved, but fracture incidence did not. So again, in lumbar spine, we see a significant increase of BMD. In the total hip, it was a trend, but was not statistically significant. The bone turnover markers, they change markedly in PN1P, But again, bone pain did not change significantly and the fracture incidence remained high. So concluding risedronate in adults with OI, type 1, it results in significant increases in BMD at the spine, though modest, and decreased bone turnover. However, a clinical important endpoint would be fractures, and no effect was observed there. I think this would be a nice transition to giving the word to Professor Duncan, and then we have some poll questions first. So may I ask to project the poll questions? Okay, let me try to drag this up. So feel free to vote in Zoom, and to encourage you, there's no wrong answer. Here the proposition is bone fragility is an inherited trait. So do you agree? Answers 1, 2, and 3, yes. Of which number 1 is yes, some individuals have rare single gene, so monogenic causes for bone fragility. That's why I agree that bone fragility is an inherited trait. Or yes, I agree, it's true for everyone to a greater or lesser extent, for example, through polygenic causes. Or thirdly, yes, I agree, it's an inherited trait, but this is not important in most cases of bone fragility because many are still due to secondary causes. Or finally, no, I don't agree. I don't think bone fragility is an inherited trait. I see most people just voted. Feel free to take some seconds. Still, I think it's finally that most people do think bone fragility is an inherited trait, and most believe more in a polygenic cause, though quite many do think that monogenic plays a large role. Yeah, let's move on to the next question.
And I was just going to say, I think that, as you said, most people are right. It is probably both 1 and 2 are probably true.
Yeah, I fully agree.
Yeah.
Thanks. So next question. What would be the role of genetic testing in a bone clinic? 1, it should be only undertaken in specialist centers. Or 2, it can only be undertaken in specialist centers. 3, this genetic testing is appropriate for everyone who comes to a clinic. Or number 4, this genetic testing is only appropriate for unexplained bone fragility after excluding other non-genetic risk factors. 5th, this genetic testing may not be appropriate for everyone, but may be more widespread than previously appreciated. Or final answer, this genetic testing is really irrelevant as everyone is going to end up tested anyway sooner or later. So please have your vote. All right, the number 1 answer. So again, nothing is really wrong here, but most people voted that genetic testing is only appropriate for unexplained bone fragility after excluding those non-genetic risk factors. And I believe we're going more deep into that in the discussion. So then another question for the poll. Osteogenesis imperfecta is usually an obvious diagnosis. Yes, no, or don't know. Right. So the majority feels that OI is usually not so obvious. So I'm enthusiastic to tell you that Professor Duncan has quite some slides here to enlighten us further on this topic. think I'll give the word to Professor Duncan, so I'll stop sharing the screen.
Thank you very much, Dr. Oy. Now I go to share screen and launch my talk, which I now press share. And I'm now moving it over to the, now are you able to see my slides in presentation format? Thank you very much. So I'd like to thank the ASBMR very much for the invitation to present, and I'd like to thank my colleague Ling for this wonderful introduction. It's been a great pleasure to meet and work with her again. I realised when we were putting this talk together that in actual fact we were asked to talk about osteoporosis genetics, but really we thought that what we're talking about today is more heritable skeletal fragility, considering monogenic disease in the bone clinic setting, and perhaps at the end we can flag up that this would be a talk for another occasion. So I have no conflicts of interest to declare that are relevant today. So why discuss this now? So I'm hoping I'm going to be able to convince you that bone fragility is highly heritable from a monogenic or a polygenic perspective, that the genetics revolution is rapidly translating into clinical practice, and that we can now screen for rare monogenic genetic causes extremely efficiently and at relatively low cost, even in cases that are thought to have a common disorder. And I'm not going to talk much about genotyping today, but except right at the very end. And that this is important because it's going to result in personalised medicine and have an impact on the choice of therapeutics. But I also just apologise for the fact that you're having a lovely view of my right ear, but my computer screen is over here, whereas my camera is over there. So I'm not going to talk today about polygenic disease much, other than to say that there is an enrichment of common low bone density alleles in individuals with low bone density and fracture, and that's true in adults and it's true in children. That we're going to increasingly see the use of polygenic risk scores in many diseases, including osteoporosis management. And it may be that in osteoporosis management that what we use this for is more for targeting of screening and potentially treatment towards those who are most at risk of future fracture as a cost-effective measure rather than as a disease prediction measure, but we can discuss that perhaps on a future seminar. And I'd also say that the phenotype of monogenic diseases, even things like osteogenesis imperfecta, depend on the polygenic background. We see variability within families who all share the same mutation. We see variability across families who have the same mutation. So it's certainly true that it's not just going to be a one gene in the absence of, the field is not bland behind the major monogenic cause. But we're going to mainly talk today about monogenic disease. So if I was thinking about the number of monogenic disorders of bone fragility, there is a long list that one can come up with. And I'm not suggesting that this is necessarily completely exhaustive, hence the etc. down at the bottom of the slide. I'd also mention that not all causes of bone fragility are necessarily associated with low bone mass. And I've put some stars there next to some high bone mass conditions such as osteoporosis and pycnodysostosис, which are typically associated with higher or at least areas of sclerotic bone and yet have got high fracture risks. For the acutely observant bone here, you'll notice also that OI, I've put a star there too. And we published a paper some years ago showing that mutations in the C-peptide cleavage region, which can cause bone fragility, can also cause high bone mass, and in a paper with many colleagues demonstrated that this wasn't just a unique case. In actual fact, there are a lot of case reports of individuals who've got COA1 alpha-1 variants in this particular region, low bone, who have bone fragility and yet have these sclerotic bone lesions. So considering OI, it's a very heterogeneous group of heritable disorders of bone fragility. It's amongst the commonest of skeletal dysplasias. And although I've put that prevalence figure up there, if one goes to the UK Biobank and looks for the number of individuals who are carrying pathogenic or predicted variants in the known OI genes, it's actually quite a lot higher than you might expect from the population prevalence. And I'll come back to this point a little bit later on. So most commonly, OI is associated with autosomal dominant inheritance, and this is most commonly due to mutations in COA1 alpha-1 and COA1 alpha-2. However, and please forgive that typo there, However, there's a very high frequency of de novo mutations. And I was thinking about this when Ling was presenting her case with this child who fractured an ankle at the age of 1 and then broke his leg and broke his femur. I mean, obviously non-accidental injury is something that all pediatricians would think about very early on. And I certainly had one lady under my care who was taken away from, who did have OI, who was taken away from her parents for several years because it was thought that this was non-accidental injury. In asking the question, how many OI genes are there, and are they autosomal dominant, X-linked or recessive, I am invariably out of date when I give an answer to this. In 2010, with the nosology and classification, this was the page, and IFIDM5 had just been discovered. But since then, things have changed. In 2013, my colleague Cynthia Lazarus published a paper which listed 22 skeletal dysplasias which had been mapped by whole exome sequencing. Just 2 years later, Chong et al. Said 3 new genes a week were being added to OMIM, obviously not all of them in skeletal dysplasias, but certainly quite an impressive rate. So by 2015, we then had 18 genes for osteogenesis imperfecta, and things have continued since then. At the moment, if one goes and looks at the OMIM stats, which I did just 1 month ago to make these slides, you can see here, and I'm hoping you can see my arrow, that the rate of new gene discovery is continuing. And this is resulting in many more genes being identified for osteogenesis imperfecta as well. So if one goes to the 2019 revision, the point I would make here is not just that there's a long list of genes, but also that it now goes over the page. You have to go on to the next page. And at the moment, if one thinks about not just OI, but also bone fragility, there's about 34 genes at the end of 2020, which I'll come back to in just a second. I went in today to look at the National Organisation for Rare Disorders, which listed 21 subtypes specifically for OI. Many of these forms of bone fragility have got some other clinical features that would suggest the diagnosis of a skeletal dysplasia, which is associated with bone fragility, but certainly not all of them. And I think that Ling gave a very good example with the WNT1 story, that there was no reason particularly that people thought about this being a form first of OI other than the clinical history of many fractures. I'd also highlight that some of these are X-linked, and these can be very tricky for people to think about because their inheritance can be non-obvious. The other thing I put is that although one typically thinks of COL1 alpha 1 and COL1 alpha 2 as the 2 autosomal dominant forms, both those forms which in men are hemizygous and several of the others might perhaps be thought of as also either dominant or co-dominant. And certainly if one looks at people who've got LRP5, if one has got biallelic mutations, these individuals might present with osteoporosis pseudoglioma, but the obligate carrier parents who are heterozygous have also got lower bone density than the general population. So I don't think these are necessarily recessive forms as such, because people who carry one allele can manifest a phenotype, as was the case with Ling's patient also. So just to point out again that one can get out of date, that was 2020, and in preparation for this talk, there is another gene which has been identified with osteogenesis imperfecta, and no doubt in the Q&A somebody will let me know that there's been another one even since November at the end of last year. So how has it happened that we've had such an explosion of information? So the first thing was the publication of the Human Genome Project in 2003, which meant we had a reference genome for comparison with sequence data. The second thing was the development of disruptive genetic technologies, and particularly pertinent to this talk, the evolution of massively parallel sequencing, allowing sequencing of multiple genomic regions simultaneously, cost effectively, and very efficiently, as you'll see in the machine here on the left. At the same time, we should not discount the effect of genotyping in the evolution of high throughput microarrays, which is going to revolutionize common disease characterization. And again, I'll come back to that at the end. The next thing is that we've got easily accessible large databases of genetic variability. And I know that this is a recorded talk and you can come back to the slides later, but I encourage you to go into these various places to rummage around and have a look at the frequently asked questions. And they often have tutorials to help you interrogate and investigate and use them well. And the last one is the international collaboration and cooperation between clinicians and researchers, informing and encouraging collaborative new gene discovery. And really, I think skeletal dysplasias are a case par excellence for that, because it's one thing to discover a variant that's segregating the phenotype in your family, but then variants can segregate by chance alone. It doesn't necessarily prove it's causative. But if that same variant is observed in another family with the same phenotype and or variants in similar areas of the gene, it adds a lot of support, as well as bioinformatics and functional studies as well. So I've put here now the next point, that the genetics revolution is rapidly translating into clinical practice, and that it's now possible to screen for rare monogenic genetic causes possibly, efficiently, and at relatively low cost. And I think pertinent to this relatively low cost was the number of times that this gentleman was seen in clinic, the number of bone densities, the trials of therapeutics, all of the things that were done that need to be considered. Back in 2013, we did a proof of concept looking at whole exome sequencing, looking at individuals with OI and with Marfan syndrome, and we had 100% success at being able to pick up these variants. And at that time, and I'd emphasize that this is nearly a decade ago, the cost was less than half the usual practice just for screening the two commonest genes, OI, Cohen alpha 1 and Cohen alpha 2. It's important that we think about this even in cases who are thought to have a common disorder. So in our data from the Australian Osteoporosis Genetics Consortium, we did exome sequencing in 1,000 Caucasian women who were at least 5 years postmenopausal, half of whom had high bone mass and half of whom had low bone mass. We identified, along with Ling and with GFOS and with many other colleagues, multiple novel genes for bone density and fracture. But we also went on to ask the question, how often do individuals who have apparently idiopathic osteoporosis actually have undiagnosed osteogenesis imperfecta? And here I will highlight that we only looked at the dominant genes that were known at the time that we did this particular study in 2017. And we characterized things according to the American College of Medical Genetics criteria for pathogenic or likely pathogenic. And the answer was 4% of them. The ones that we regarded as pathogenic were previously reported in osteogenesis imperfecta, or the same base or amino acid reported previously, or involving a glycine. They were all conserved, novel, rare, or rare, and predicted to be deleterious by at least one, and usually 3 of the protein prediction algorithm platforms. And we observed this with Cohen alpha 1, Cohen alpha 2, and some of the other then known autosomal dominant causes. Looking at another study that was published in 2018, this was a study looking at young people less than 55 who had severe idiopathic osteoporosis with a Z-score less than -2, just like Ling's gentleman. And they did panel sequencing here just for 5 OI genes and some of the other genes associated with bone fragility, including hyperphosphatasia, and some of the loci associated with bone density in population studies. And they're looking at this cohort. There were 11 rare or novel variants that I've listed there, and a high prevalence of pathogenic LRP5 variants. And LRP5 is a difficult gene sometimes if one assesses a variant, because as people would know, some variants are associated with high bone mass, particularly if they're in exons 2, 3, 4 and involved in the first propeller of LRP5 protein, and others elsewhere are more associated with low bone mass. But I think this really emphasizes the benefit of doing sequencing, even if you think that all that's going on is idiopathic osteoporosis presenting in a young person. And towards the end of this, and we can discuss this in question and answer session, I've put some suggestions as to people whom I think it would be worth looking at. Why does it matter? And it matters because conventional osteoporosis approaches aren't particularly successful for fracture prevention in adults with OI. We've talked about this with respect to the 2 papers that Ling presented, and I would, for completion, mention the study that was a randomized controlled trial with alendronate, where again, similar to our study with risodronate, bone density improved, but fracture rate did not. I'm aware at the moment there's a study that's going on with denosumab, which is yet to complete and report, but I'm very excited about the project which is going on with frezolizumab, which is being led by Brendan Lee in America. And I think that this is going to be a really fascinating study to look at as really the first targeted treatment for osteogenesis imperfecta. We won't have time to talk about that today, but again, if people would like to request this, I'm sure that this would be something that the Education Committee would be delighted to present a seminar on down the track. The second thing is that People who have OI do get side effects from these drugs, as do the general population. But if you're going to treat adults with bisphosphonates for many years, you're going to run into problems, as was reported by Bente Langdal and her team recently as well. The next thing is that OI isn't just bone fragility, and these individuals, one needs to think about heart disease, one needs to, and valvular lesions, as one does with some of the other forms of bone fragility as well as deafness and dentition issues. And it's important for the family, as I've mentioned, not just for genetic counselling, but also for stopping for an explanation of non-accidental injury. Although I would mention also that just because somebody has OI doesn't mean they can't be the victim of non-accidental injury as well. One should just keep an open mind there. So what are the screening options that one has? And I've put up here the three major ones I think most people would be familiar with: panel sequencing, whole exome sequencing, and whole genome sequencing. With panel sequencing, I'll come back to in a minute, but there are many commercial options and many of these are highly reputable, and I'll talk about them in a minute. Whole exome sequencing, often people will actually do what's called a clinical exome, where they will report on a number. They'll often do whole exome sequencing, but they'll only report on a certain number of genes, if you like a default panel, and we can talk about that. And whole genome sequence similarly is often only analysed as a clinical exome and only looks at the things that you might be particularly interested in. So panel sequencing is now established within clinical delivery for many countries, including the United Kingdom, but not at the moment as an established delivery in Australia, at least not as of the discussions that I had a week ago with my colleagues. It's quite cheap. It's sensitive and specific as a means of sequencing known disease genes, but by definition, it's a defined list set of genes, so you can't use it for new gene discovery in the event that somebody was negative for those genes. It gives excellent coverage because there's only a few genes that are actually usually put on the chip, and it minimises some of the ethical issues that might be raised with more agnostic approaches, such as some whole exome sequencing and whole genome sequencing, such as incidental or secondary findings. However, despite all of these really good points, I'd just highlight it may not necessarily be the fastest or the cheapest technology for all illness presentations. And certainly in a study a few years ago, comparing first-line use of whole exome sequencing by panel approaches, and people could choose up to 3 panels, and that was by expert clinical geneticists. Using whole exome sequencing shortened the diagnostic odyssey, and it was more effective than panel sequencing. And as I've mentioned already, in actual fact, many reported panels are in fact whole exome cut down anyway, so it might be faster for you to go that way. I would just emphasise here that this is not an exhaustive list, and I am not affiliated with any of these particular companies, and I am not recommending any of these particular companies or products, but I want to put it up just to highlight that there are many accredited commercially sequencing providers that are available, particularly for panel sequencing. And I will just highlight one here, which is Invitae. Yesterday I went in to look at the panel to see what did they have for the bone fragility genes, and neither you nor I can read the small print on the screen, but I'd point out that at this point they are screening a whole number of genes which are associated with bone fragility. I think it's 46. It could be 48. I can't see even with my glasses. But the point is that this is something which is available with genetic counselling, with support, which has to be ordered by a clinician, and it's fed. The results are fed back to a clinician. And so even if it's not available where you are, from the point of view of your formal healthcare delivery system, this doesn't mean it's not available for your patients. And you might want to have a think about this. Whole exome sequencing has been extremely successful for new gene discovery and for diagnostic use. Now, this is perhaps not surprising. 85% of Mendelian disorders were predicted to arise from coding mutations back in the 90s. I think we'd probably accept that this is probably an underestimate. And Sutton's law is that one robs banks because that's where the money is. So it's not surprising that if we look at the whole exome sequencing, we're likely to find a lot of mutations if most disease is related to protein coding mutations. Whole exome sequencing is certainly cheaper than whole genome sequencing for a given coverage. And there are large databases detailing exonic variation, which I've mentioned already, but such as NOMAD. And this really aids attribution and variant classification. It's been very fruitful in diagnostic yield and clinical delivery, and I put a recent review article up there. And this includes high diagnostic rates, including in consanguineous and families and in singletons. It certainly has a higher yield if one sequences parent-child trios compared with singletons. but it's not ideal for detection of copy number variation or for detection of very large indels. So whole genome sequencing certainly gives very even capture of the exome and obviously the genome as well. And it's very good at picking up large indels, copy number variation and chromosomal rearrangements. At the moment, it's still at a higher cost compared with panel and WES, but this is coming down very quickly and fiscal concerns may not be relevant within a few years. The large databases that we have detailing exonic variation that inform WES are not as detailed as yet with the whole genome, although this is rapidly changing. At the moment, it is still quite tricky to prove causality for non-coding variants. And certainly very few monogenic disorders have been described to date, which are due to non-coding or splice site variants. Although I'd give as a great example of one of them, Van Buchen's disease. So bone disease is one of the few exceptions to this particular comment. At the moment, WGS has not demonstrated superiority to WS in diagnostic utility. And at the moment, we really don't know to the extent to which WGS will ultimately provide an answer where WES doesn't. So this is a watch this space comment. So thinking about variant classification, by and large, I think most people would use that of the American College of Medical Genetics and Genomics and the Association for Molecular Pathology, which classifies variants into 5 categories based on a number of different levels of evidence, which I'll go through. So, and these include population data, including the minor allele frequency, computational and predictive information, functional information, whether things segregate with disease, whether it's de novo or not, allelic data, other database data, other families, and so forth and so on. And these variants are therefore given different weighting according to all of these levels of evidence. What to do with variants of uncertain significance and what do they mean? Well, these are variants which are insufficient. We don't have enough evidence at the moment to classify them either as completely benign or as pathogenic. It's likely that with time and as more information becomes available, particularly as we in the clinical community report cases which have the same or similar phenotypes associated with the same variant, that various of the VUSs may end up being reclassified as pathogenic or likely pathogenic, or more commonly, so far, benign or likely benign. And I've put there a comment as to whether the launch of DeepMind, which some people might have seen over the last sort of weeks to months, which is a large artificial intelligence algorithm-driven protein classification database and protein folding prediction, whether this improves. VUSs are a long-standing challenge in genetic testing, and certainly the larger number of genes that you interrogate, the higher the probability of generating a VUS. But it's not just the provenance of agnostic approaches such as WES and WGS, and certainly it's been a problem in cancer genetics for a long time. For example, a third of the variants that were picked up in just a 25 gene panel for women in breast cancer ended up being classified as VUS in this study back in 2017. So this is a problem, but I'll just give an example of where we can end up sometimes taking a VUS sort further forward. So we had a young girl who was 5 who'd fractured her wrist, her humerus, and both of her feet. Her paediatric care team had organised panel sequencing, and this reported a variant of unknown significance in PLS3, which is one of the known X-linked osteogenesis imperfecta genes. It also found 2 other variants, one in LRP5 and one in BMP1, and please forgive the fact this is italicized. Looking at her family history, her mum had osteopenia but had never fractured. Her uncle on her mother's side, who was in his late 30s, was known to have osteoporotic range bone density, and he had broken his right wrist after a fall from onto his outstretched hand. He'd fallen off his bike and had a lot of fractures, and he was also becoming progressively more kyphotic, although I don't know the details of his vertebral imaging. Her maternal grandmother had had her menopause in her 40s, and then it started breaking toes and ribs, and then she was on a jet ski and had a lot of fractures, including breaking her back in 3 places. Who knows what that means in terms of fragility, but bone density at that point, in terms of low trauma, but bone density at that time showed severe osteoporosis, and her maternal great uncle had multiple fractures and was extremely kyphotic. And we just did Sanger sequencing in the extended family and demonstrated that the uncles, both the great uncle and the uncle, were hemizygous for PLS3 variant, and the mother and the grandmother by definition were obligate carriers. So in this family, the variant segregated completely with the phenotype. The mother and the grandmother, who had one X chromosome that was normal and one which carried this particular variant, both had low bone density, and the homozygous uncle and great uncle had both got extremely low bone density and multiple fractures. And there's a 1 in 32 chance that this variant would have segregated in this pattern in this family if it were not causative. So I think in this family, I think we are going to be fairly confident that this is the cause in this young lady. So when is it appropriate to think about monogenic causes? So this is my sort of things that I think is worth thinking about. Certainly severely low bone density at a young age, again noting that low bone density is not invariable in OI. Children who have fractures in utero, vertebral fractures in childhood, typical osteoporotic fractures, such as a Colles fracture occurring in a premenopausal woman. And I've got no idea what age one might think about that in a man, but certainly less than 50, and whether one would choose less than 60 is an arguable point that we can come back to. If there are genotype-specific associated features, such as blue sclerosis or valvular disease, that's a very strong pointer. I think a family history consistent with typical inheritance helps a lot. But again, I'd mentioned that given the high prevalence of de novo variants, an absence of a family history does not rule this out. And I've put here, it can be difficult to discern for recessive OI and perplexing and X-linked OI, unless you think about these as possibilities. And an absence of other secondary causes. I think if you've got a very obvious cause, like high-dose steroids for 30 years in the context of somebody who's got a renal transplant, I don't know that you need to go looking for something else. However, I do think that rapidly we're going to see patients coming into our clinics who have already had sequencing and or genotyping done for other purposes. And it behooves us to become conversationally literate in this space, even if we haven't ordered the test for our patients. So there's as a practical approach, this was a paper that's just come online. It was accepted on the 29th of June and it came online, I think, on the 6th of July. And I believe it's a freely available paper, and I would encourage people to go and have a read of this very practical approach published by colleagues. And the very last thing I just want to say is that both Ling and I have worked for many years with colleagues, and there are now over 500 loci known to be associated with bone density. And I think we are going, although today we've not talked about genotyping at all, two very obvious ways that we're going to be using this is going to be generating polygenic risk scores and thinking about it with pharmacogenomics down the track. And ultimately, I think we have got a hope that we're going to be having personalised medicine. We're going to be better at diagnosing, but it's also going to help us with therapeutics. It's going to help us with OI and telling the difference between that and common or garden osteoporosis. And it will help us in terms of thinking about the efficacy, the safety and the specificity of the medicines that we're choosing according to the issues that our patients are presenting. So at this point, I'd like to say thank you very much and to hand back to the chair. And I know that both of us will welcome the opportunity to talk through the question and answers. But I have two questions to poll now. So if we might, I'll stop sharing and ask if we could launch the next two questions, please. So here we have another one. If you do organise panel sequencing for your patients, do you frequently encounter variants of unknown significance in practice? And if so, what should you do about them? So you can have A, I report them and I consider them potentially pathogenic. 2, no, I find them misleading, so I ignore them. 3, I don't get given results of variants of unknown significance. 4, I have no clue. And 5, I never organise panel sequencing. So I'll just give that one another 10 seconds or so. And I think this question really this question was to provoke thought, because I think that, as I said, I think it behooves us to become quite literate in this space. Some laboratories will not report back VUSs. Some laboratories will report back VUSs. And I think we need to know before we order a test what we're going to do with the results. And how we're going to interpret it for our patients and with our patients. So I think that it's somewhat evenly split between people who never organise it, and maybe this presentation may prompt you that maybe you will do this in the future, and those people who feel that having got a result that they will report them and consider them potentially pathogenic. And my own approach is certainly I counsel patients before I do the test, and I counsel them after we do the test. And I think the case that I presented, the Ling's case is interesting because at the moment, the two children who are late teenagers haven't yet come in to be tested. So she doesn't have the capacity in her family yet to do segregation. And even if she were to do that in her family, because at the moment there's only two children and the dad's got a 1 in 2 chance of transferring it through to either of them, it might be supportive, but I don't think it would be diagnostic. Whereas in our family, because we had a bigger family tree, I think it was more suggestive that this is indeed causative. However, it's still a probability that that variant that we identified could have just segregated by chance. And what will be conclusive is either functional studies or demonstration of this variant in another family. So could we please have the next question? So faced with the VUS, how would you go through things further? Pedigree analysis, basic science functional experiments, bioinformatic lookup such as in ClinVar, sequencing with a more extensive panel, exome or whole genome sequencing, thinking about a polygenic risk score, and this is to make the point again that even rare variants of high impact exert their effect in a background of polygenic, in a polygenic background. And ignore for now, it'll all become evident later, and I don't do anything else. I'll just give that another 10 seconds. Okay, at this point I will then, some people I think are very, so I think that there's some very practical approaches that people have put that, and actually for those people who've answered, they're more or less evenly split. Thinking about pedigree analysis and Sanger sequencing, doing some basic science functional experiments, and which are not cheap. And I think again, working with colleagues around the world is a very good way of taking this forward. And then bioinformatic lookups, such as places like ClinVar, can help to inform how you take this forward. So I don't think any of those are wrong. This was more just to provoke discussion and thinking. So I think at that point, we are open to Q&A. So I shall return to the chairs and ask and stop sharing my screen.
Thank you very much for these excellent presentations. It's a lot of information. I think you also touched on all the difficulties regarding to choose whether to test or not to test. So actually, I would like to start with a question about the professional opinion of Dr. Oei about a patient I just saw this morning. I wondered what you would advise. A male patient at the age of 40 with osteopenia with traumatic major fractures like the pelvic bone, the humerus, wrist, vertebral fractures, but without a family history of fractures, no OI genotype specific features like deafness, valvular disease, or blue sclerae, and other secondary causes like celiac disease, hypogonadism, etc. were ruled out. Would you advise to perform genetic testing? And what about the possibility to find variants of uncertain significance and the fact that there is no family history?
But yeah, fascinating. So there was one trauma where all these fractures occurred, and
no, it's all
different.
Different fractures
Okay.
at different moments with various traumas.
Also really interesting. And what were the DEXA results?
It was, well, about minus 2.6, minus 2.5 in both the vertebral column and the hip BMD.
Sure. So you could debate if you do the testing. I do feel inclined to do the testing. I see Professor Duncan also raised her hand. You might want to add on that.
I did, but I was going to let you expand first. But what I was going to say is, if one goes back to look at the stuff from the AOGC, it was more common to pick up that people had variants in their known OI genes than it was to have celiac disease. So we all screen for celiac disease. We don't even think twice about it. And yet you're much more likely to pick up a variant in a known OI gene. So I think that I just wanted to give that as a perspective. And the other thing I wanted to just mention was that your comment about the bone density and the Z score, that even for a given Z-score, which is usually low, please don't get me wrong, although some OI occurs in high, it's usually low. These people fracture much more than you'd expect for a Z-score, for a given Z-score. As both Ling's case and your case highlight there, Elizabeth, you know, this is your person is not that old, and yet they've had pelvis and wrist and various other things. And the same with Ling's person, his Z-score was -2, which is not great, but it wasn't like -4, and yet he'd had multiple fractures. So, the two things I wanted to say is this is more common than celiac disease at a population level. And second of all, these people fracture more than you'd expect for a Z-score, even though their Z-score is usually low.
And just to follow up on that, before I give again the floor to Elena to ask a question, what is your opinion on the possibility to find variants of uncertain significance, since that is a high risk, of course?
Yeah. So here again, this depends on how many genes you look at and which approach you use. And it also depends on the report, whether you personally as a clinician involved are dealing with a lab who reports back VUSs. Some of my colleagues find that their labs will not report back VUSs. They will only report back pathogenic or non-pathogenic. I personally feel that if somebody is sufficiently, I think that most clinicians who are ordering panels actually do understand the significance of VUS and have counselled their patients both before and after, before doing the test and afterwards. So my personal feeling is that that the chance of getting a VUS will depend on the number of genes that you look at. However, even if you do get a VUS, for many patients, they actually find that very comforting to know that there might be an explanation, even if it can't be a definitive explanation.
Yes, the panel has been expanded. So in our situation, 41 genes are tested in the panel that we ordered.
Yeah.
So odds of getting a VUS increases. On the other hand, the odds of getting a known pathogenic variant throughout the years also increasing because we get to know more about the genome.
Yeah.
Yeah. And
thank you.
Yeah, we have. Sorry.
I should say patients like to know. They are interested and keen in their own illness.
Yeah, it's true. Yeah, we have been getting some late coming questions. I will try to go through them. Dr. Shalom wants to know if there are any significant data on pharmacogenomics at present.
Yeah. So the answer is that there's a really wonderful website called the CPIC, which is the Clinical Pharmacogenomics International Consortium, I think. And I would urge that you go and look at the CPIC. There are multiple drugs and there are multiple variants that are listed. At the moment, the last time I checked, which was about 2 months ago, there were none of the drugs that we use for osteoporosis have known pharmacogenomic significance. Which doesn't mean that that won't be the case in the future, but I would strongly encourage you to go and have a look at that because it lists drugs where not only are there known pharmacogenomic interactions, but also a grading where there are guidelines and the grading of the evidence and those genes which are known to influence the drug. So you can interrogate it both ways.
Yeah. Thank you. And then a question from Dr. Lienhardt. He says, if there's a VUS in a patient with a fitting phenotype but no family history, it would seem appropriate to classify it as a supportive causative gene. And if you would also go along this way of thinking, yes.
Yeah,
yeah.
Go ahead, Emma. Yeah, I do agree with this participant with the view. Yeah, but go ahead.
I was just going to say what would be really lovely in this person's family would be if you could have mum and dad and do Sanger sequencing to see whether this is a de novo variant, which would be nice. Again, that doesn't prove it's causative, but it would help explain perhaps the lack of the family history. Yeah. So again, I think that this comes down to the fact that there is a high probability, there is a high incidence of new variants. And so this business about lack of family history is not, it's not just when mum and dads are not available, it's when there are, or when mum and dad don't have a phenotype, it's also when mum and dad aren't available, when you've got adopted individuals and so forth and so on. So, so I think this is difficult, but again, I would, this is where I think genetic counselling before and after can help. I think also watching how patients do on treatment, in such a situation, would it alter your management? And that's the question you need to, so there's explaining the patient, and then you think, how would this alter my management for this individual? And I certainly think you might be quite careful about, even Ling's patient fractured despite treatment, and therefore people rethought things.
Yeah. A question maybe that I would like to ask you, it's about pregnancy and lactation-induced osteoporosis, and we have looked into it and found, using also a panel, and we have found quite a high incidence of Wnt genes mutations and also collagen. And then there are these data, the histomorphometry data about low bone formation. So I was wondering if this more or less is along what your experience shows in these patients, or would it be also a group of patients where it would be maybe important to test?
I think absolutely. So
Absolutely.
that we will necessarily find that all pregnancy-associated osteoporosis, lactation-associated osteoporosis is necessarily due to monogenic in origin, but I certainly think that some of them will be individuals who are form firsts of OI or other forms of monogenic bone fragility. And again, it provides an explanation and it helps inform management for future pregnancies. So, so I'm not saying that everybody who's going to have these conditions are necessarily going to be monogenic, but it would seem to me that this is a population that is enriched with individuals who are likely to be to have a monogenic contribution to their bone fragility.
True, and we wrote a review on PLO with the ECTS Academy, published very recently, all together. So I'd like to point also people participating here to review that one. And also, that's what Professor Duncan pointed us to. If you do find such a mutation in these young women, it has a lot of consequences, because then you might choose exactly not to treat those with the bisphosphonates, right? Or well, even therapeutic question.
Yeah. I think also the therapeutic aspect is also another consequence. Yeah, of course. Yeah. Okay. Maybe, oh, they're coming in now, but maybe one last question. Yeah, from Dr. Salika, some references or websites regarding pharmacogenetics in osteogenesis imperfecta. I think, Professor Duncan, you mentioned in your previous answer, I don't know if it's something that we should also write on the chat, references regarding pharmacogenetics.
So the I'll put the CPIC website in the chat. It's not specific to osteogenesis imperfecta. I can't see the question at the moment. That's the exact wording of the question.
Yeah, so it's about references or websites regarding pharmacogenetics in osteogenesis imperfecta and other rare bone disease. So yeah, I think so.
Yeah, I think so. I know that there are websites that pertain to osteogenesis imperfecta, but many of these talk particularly about management in children. And I think management in adults, I would direct you more towards review articles than necessarily websites. Although there are some very detailed Cochrane reviews on bisphosphonates and other medications in osteogenesis imperfecta that detail not just what the data in children, but also detailing the data in adults. But I do think that this is an area where we're going to see, well, hopefully great news, but certainly changing profile of therapeutics in the near future based on the studies in fresolimumab and similar compounds.
Okay, thank you very much. I think in the interest of time, we will now have to close the session. Thank you, Professor Duncan. Thank you, Professor E, for these wonderful talks. They were really multifaceted, and you also pinpointed the clinical relevance. And I think it's very important also for our audience. And thank you very much for joining us in this webinar. We will be back after a short summer break, so in the early fall, and we are also contemplating doing a series of rare bone diseases. So the subject, the date will be announced shortly, but we will be very happy to meet with all of you again after the summer break. Have a wonderful summer.
Bye-bye.